And I'm presenting the case that is going to be performed in Bicêtre. This is a 39-year-old man. He had a medical history of smoking. He got a subarachnoid hemorrhage with a WFNS1 and a fissure 2. As you can see, it's a pretty severe subarachnoid hemorrhage. The angioscan has demonstrated this Acom aneurysm pretty nicely. This is the angiogram that was performed at the time of the treatment in emergency. So we recognize the aneurysm here. This is the 3D picture of the same aneurysm. There is another daughter sac at this level, which is, of course, some tricky things at the time of the treatment. This one looks pretty forward for regular coiling. These are the measurement of the sac of the aneurysm, and this is a measurement of the second daughter sac, just on the side of the first one, which is a pretty tiny one. The treatment was performed in emergency by coiling and remodeling. The balloon was located in front of the neck, and the coils were delivered from the opposite side in the sac of the aneurysm. This is a result after the treatment. And the patient had a very favorable outcome with an MRS at level 1. 4 months later, the patient came for a control angiogram, and this is what we see. There is a little bit of remnant at the level of the neck. Of course, this one is still visible, but we didn't do any treatment on it. This is the 3D of the patient. You can clearly see that this one is completely independent, and there is a recurrence at the base of the aneurysm, which is not that much, but which does exist definitely. There is some dysplasia when you merge the two sides, the left and the right. You can see that it does extend up to the level of the A1, A2 segment, daughter sac here, and just behind there is a small recurrence of the aneurysm. So this is after subtraction. So we have the vessel, which is a little bit dysplastic, and we have something that belongs to the neck and the remnant of the aneurysm, and something that is this one on the other side. There is an A1 segment on the opposite side, which is small, but which is patent. This is some of the view when you turn around. You can clearly see that it's a pretty dysplastic Acom aneurysm. And it's not going to be easy to solve the problem if you don't use the new tool that we have, which is basically flow diversion. This is a view and a better view of the remnant, which has been calculated this way. 4.7, 2.7 on the other side. This is another view here, and you have the diameter of the vessel according to the potential course of the catheter, which is going to be delivered. The choice was to deliver the stent from the left A1 to the left A2, covering that one, and redirecting the flow from covering the origin of the Acom. This is view from the posterior aspect, so you are thinking that the stent is going to cover this one, come here and get here. It's a small vessel, but it's not too much a big deal for today. The treatment will be performed using this kind of base camp. We have a long sheet, which is a ballast 80 centimeter from BALT. The catheter is just a regular 4 French. And I didn't touch anything, but it comes okay. Okay. I touched the screen. Okay, I'm sorry. So this is where we are. This is the material. This A1, A2 segment will be catheterized with a netway and then a hybrid 12-14 guide wire. And the treatment is going to be performed with a brand new Silk Vista Baby, which is the only one in the world for the time being, going to navigate through a 17 catheter. The team performing the treatment in the middle, Laurent Spelle, on the left, on the right of Laurent and the left of the screen, Christian Mialéa, and our fellow Thibaut Jacquet. I just want to remind you that there is a paper that can be published from the department regarding the flow diversion treatment of aneurysm on the complex region in the Acom anterior communicating artery. Which stent placement strategy should I use? This is something that I really advocate you to read, and this is basically the different situation and the classification that has been proposed. Of course, it's not my purpose to demonstrate what is written in this paper, but I do advocate you to try to listen and to read and to understand what is the philosophy of that. So depending on what you do here, you can get in an H1 situation, which is this one, with 2A2 and an Acom here, 83% of the occlusion by delivering one on the other side. And this is a potential thromboembolic event that have been reported in this context using all kinds of devices that were at our disposal. This is another situation which is A2. You have a different type of occlusion depending on the anatomical situation. So let's go quick because it's going to take too much time and you can read the paper. Well, it's not too much a big deal. So let's go to the live case and let's move to B7.
Okay, so we have prepared the patient. Can you send the 3D? Yes, you have the 3D. Probably you have been explained that it's a dysplastic junction between A1 and A2. There is this small aneurysm which was not treated in emergency, so I presume that the guide wire will always go in the small aneurysm instead of going distally. Can you show in the middle the simulation for the stent, the Sim&Cure? So we have sent the 3D acquisition. We have sent the 3D acquisition to the Sim&Cure workstation. And as you may see, you can select the device. So it's a Silk Vista. And of course, this Silk Vista 20 millimeter is definitively too long. Let's have a look to the 15. 15 could be suitable, but we have tried to simulate the 10. The 10 is definitively too short. So each time I change the distal position, you see that automatically you have the repositioning of the proximal end. Of course, you may play with the push you will be giving to the flow diverter. So it's a normal push. So we always try to simulate the highest push. And you see that if we would push it a lot, it would be definitively too short. So I think the good balance is the 15. Another concern is this frontal branch on the left side. It's difficult not to cover it because we will be too close from the neck of the aneurysm. So definitively, I don't want to take the risk of having the flow diverter protruding into the aneurysm. So this is more or less something what we'll be doing. We'll try to not cover this distal branch, but definitively we'll have to cover this proximal one. As you can see on the 3D, you will better see the anatomy on the 3D. So this is the branch that I will cover. This is the branch that I will preserve. So probably we'll start around here. So for the time being, we have the headway 17, which is in the carotid siphon, and will be working now.
Okay, so here we are. The strategy has been deployed and explained. Obviously, nobody cared about this prefrontal branch, which basically won't be occluded immediately, and if it's occluded one day, it will take some time to be recharged by the PL circulation. So this is real-time catheterization. Sometimes the ophthalmic artery is just a step to go through. Okay, we use very frequently the 3D roadmap. As you can see, it gives a lot of flexibility to understand the anatomy and choose the right position. It's a short subarachnoid carotid, so sometimes it's pretty difficult to capture the origin of the A1 segment. That seems to be here. So he's going to reshape the wire because it's not curved enough. We can probably lose quite a bit of time to catheterize the M1 segment, because you will see when A1 segment is already catheterized, the navigation with the 17 is easy, and the deposition of the stent is a piece of cake. So honestly, we still have time. So wire has been reshaped. When it's a little bit desynchronized from the CD roadmap, you can do it and reset it manually.
What is he using as a guide, as a wire?
I don't understand what you are saying.
What is he using as a wire?
Sorry?
What is the wire?
Guide wire. I don't remember. Synchro 14.
Okay.
So the concern is definitely the small aneurysm, which is at the base of the Acom complex. So you have to be really cautious. So this is probably the most difficult part of the procedure, to try to get out of the trap, being in the small aneurysm and having a concern. So the daughter sac is not that easy to see unless you probably switch completely on the side and laterally, but obviously you lose the visibility for the catheterization of A1, A2. So you have to compromise. I don't know if you have a clear view of the way they are working. There is a very stable table which is covering the patient, and it's very convenient. You can
Depends on where it is. If it's a
fix everything on the table. No ondulation, no irregularity. It's a very easy table to deliver over the patient. It has been done by Custom Med, which is a Polish company. It's a very light table, easy to manipulate, easy to deliver by the technicians when they prepare the patient, and absolutely wonderful to use during the treatment.
put 5 coils, say 4 or 5 coils in the stent.
So using the 3D roadmap, you can change the position to understand the one which is best suitable for getting this A1, A2 navigation.
I mean, the same.
Here we have a pretty nice view of this daughter sac at the base of the Acom segment, pointing down and a little bit posteriorly.
If I'm concerned that the patient doesn't take their anti-psychotic medications, they don't.
Because it's a sharp angle, as you can see here, there is a sharp angle here and a sharp angle here. So as far as the microcatheter is already located in this one segment, Laurent is going to switch from the synchro to the Terimo double curve.
I don't know that.
Of course, you can imagine that it makes a big difference between navigating your flow diverter through a 17 catheter compared to a 21 or a 27. That makes a big difference in terms of navigation. It's a real plus. So as usual, when there is a tight angulation here, the catheter is pointing down and you have to go in the other direction with the wire. So be careful. You see how comfortable it is to work on this table. Everybody can, put his hands, even the elbow, and it's a very relaxing. So we need to find a better view of the junction between A1 and A2, otherwise it's a pretty dysplastic vessel and it's not that easy to navigate. You are hooking the wall, it's crushing the wall, hooking the wall. With the 3D roadmap, when the micro wire is going to be manipulated, you have a chance to see if it's pointing towards the sac or outside of the sac. Otherwise, if you look at this one, you cannot see anything. So Laurent says that he doesn't have too much control with this one, and probably the curve of the Terimo 12 is not sharp enough. So he will be taking back the synchro wires with another curve, a little bit more tight, and to try to cross this junction. We didn't choose an easy case, but it's life. It's nice to see, cases that are, facing problem, and the way gently you take your time. It was the same concern yesterday. We had a lot of trouble to get access, to navigate, but finally everything went okay. You just have to be patient. And also, what's very important, you have to have access to all kind of devices on the market. And this is definitely one of the big limitations. When we travel and we do cases outside, we are sometimes blocked by the fact that we don't have access to all kind of devices. And this is a tremendous limitation. The fact that the patient has already coils in the sac, it's some limitation. You hook the coils, you are trying to avoid the aneurysm, you are hooking the coils, you want to get this tight curve. It's this plastic Acom segment, it's multiple different barriers to get access to the distal A2. But this is our life. So he moves back to the synchro with a tight, probably double curve of the synchro. And that's done. With the same shape as the Terimo, but done on a 14 wire. It gives a good look at the slack. It goes in the sac itself, in the huge Acom complex. So you can imagine that here we are working with a 17 catheter, which is really wonderful. But if you had to navigate with a bigger one, it should be a different song. Now the vessel have been straightened. The complex looks much better. The catheter is moving easily. Control angiogram to have another good roadmap. Before the working projection for delivering the stent has been chosen on the 3D picture prior to the treatment. This is the one that Laurent is recalling, so you just call back the 3D picture and it goes back directly with the gantry. So this is a new modality with a new anatomy due to the stretching of the A1, A2. He's repeating the angio to have a better contrast. On this picture, we do what we call a smart mask. So this is, you can see here, the Silk Vista Baby, which is introduced in the hub. Now he's looking back to the measurement of Sim&Cure. So he's looking at the distal landing. As far as you have the distal landing with the calculation of Sim&Cure, you control the proximal delivery. So understanding where is the distal landing, you get the proximal one. So that's the reason why Laurent came back to the Sim&Cure measurement. And he will start the deposition of the stent just at the level of the Sim&Cure in compression, which means that it's not going to deliver distal and pull on it. It's going to be done in compression. So this is a SILK Vista. Absolutely zero difficulty to push it. Of course, it's already there. Imagine the facility to deliver it. Come down, select the distal landing. According to the information he got from Sim&Cure. So here, you know, there is the superimposition with the coil mass. So he wants to have a better view. So you see on this position, you have a better view. It's covering by the coils. So it will be recapturing the stent, delivering a little bit up and continuing down. So the recapture is easy. Navigation up is easy. So it's a better view. You have the axis of the vessel outside of the coils, more or less. So you switch from subtracted and non-subtracted picture. The point of delivery of the stent has been fixed. And you switch from subtracted to non-subtracted. It's very interesting. So the tip is there. Just try to avoid covering the upper branch. Now the whole scene is in compression. So we are at the level of the neck. Just with one hand, you can deliver, push it. It deploys very easily. It's even not necessary to go back because you see that very nicely. So you have a very good view of the, extremely visible. This is a DFT technology. So, you see the stent just on a regular fluoroscopy is perfectly visible. You even don't need to do anything special. So this is the final result. So we do the vaso-CT and the treatment is done. So tremendous advantage navigating in a small vessel, in a small catheter, 17, easy to push, easy to deliver, easy to see. Big advantage. That's a true input. Look at that. Just on the fluoro, easy to see. Of course, due to the coils, the vaso-CT will be a little bit blurred, but we'll get a possibility to see the stent through it. The patient is pre-medicated with the same regimen that the one we are using for all kind of stent. It's double antiplatelets with aspirin and ticagrelor the day before the treatment, and then for 6 months. And then we stop according to the result on the control angiogram. So this is the vaso-CT acquisition. And we will do the reconstruction of the vaso-CT in front of you to show you what it is in real time. Okay, so here is the vaso-CT, which is processed in real time in front of you. You have a reconstruction. We already reconstruct in a smaller volume. This is a process of reconstruction. So this is a rough pictures. A little bit of artifact, and at the time, because we don't have that much time to with the network and the satellite, so there is no metal artifact reconstruction, but you can see clearly there is a pretty good apposition, very good apposition of the stent on the wall, very good coverage of the neck. Very good apposition of the stent.
Jacques, how many times do you find that the apposition is not good?
Very
and do
rarely.
Something about it.
Yeah, with this type of technology, it's very rarely, especially when you deliver the stent in compression. Honestly, you know, it's an easy stent to deploy. It's very well under your control. And it's no, we don't have that problem with you know, the delivery of the stent and their position.
So is it worth doing the I mean, of course it's easy to do it, but it seems to me that almost or every time you do the expert CT, it looks good. So why do it?
No. Well, we do it because we love to confirm that it's well opposed to the wall of the vessel.
Do you ever angioplasty?
Yeah. No, it happens, but you know, very rarely. But it happens, of course. You know, all kind of devices, you can get a necessity, you have a necessity to angioplast, but it becomes rarest because we have a much better control of the delivery of the stent. I'm not speaking necessarily from the Vista, which is very easy to deploy and deliver, but all kind of stent, we have a better understanding of the way it behaves. So.
And with angioplasty, you do with a scepter? What balloon do you use in this type of vessel?
Oh, you know, it depends which catheter you use to deploy the stent. If you use a Copernic double lumen, you can deploy the silk, and the balloon is already there. So, you know, even if you don't need it, you can angioplast the stent because you are 100% sure that you, you know, oppose the wall of the stent the stent on the wall of the vessel. If you don't have this double lumen balloon and the silk, if you use a pipe or if you use a thread, we usually use a scepter.
Tudor, CT, Vaso CT or Dyna CT is really almost...
Yeah, it's easy. Yeah,
it's routine also. Yeah. And, you know, we tend to do it for two purposes. One, to see the entire brain, make sure that we did not have a small subclinical perforation, because these patients are on dual antiplatelet therapy, and you have to think about it. Because there are some cases of perforation, but the patient is so well sedated that the blood pressure and vital signs don't change. And then
it leaks over time, and then a few hours later, it becomes clinically manifest.
That's true. And then we do a reconstructed one on the device to see the apposition, and sometimes you have to angioplast.
No, but to look at the potential bleeding with perforation, you don't need to do a vaso CT.
You don't need to vaso. You do
a regular CT, which is part of the protocol. When you manage a team, you know, you have to follow protocol. Otherwise, it's Spanish hotel or Spanish auberge, I would say. Everybody comes, do what he wants, and get out.